Welcome to This Explainer. Today, we're tackling a massive question that a lot of folks face after a skin cancer diagnosis. How do you actually navigate the choice between Mohs surgery and a standard excision? I know it can feel totally overwhelming, but we're going to break it down clearly and simply using the comprehensive Skin Trust manuscript. We're getting right to the facts so you can make informed decisions. Before we really get going, we need to set our foundation. Evidence current as of July 11, 2026. Reviewed by Dr. Thomas Hocker of skintrust.com, a triple board certified dermatologist, Mohs surgeon, and dermatopathologist, author, and educator. All right, with that objective evidence-based groundwork laid, let's just jump straight into the direct answer. Here is the direct answer you need right up front. Mohs surgery is usually the stronger option when a skin cancer is high risk, recurrent, poorly defined, or located in an area where saving normal tissue really matters. Meanwhile, standard excision is often an entirely reasonable, sound choice for a well-defined, low-risk tumor in a more forgiving location. It really is that simple at a high level. But why? Okay, let's dive into this by translating a little bit of clinical jargon. Both operations obviously aim to remove skin cancer, but the absolute most important difference isn't the shape of the incision or how fancy the name sounds. It's literally all about the surgical margin. The margin is just the physical edge of the removed tissue. The fundamental difference between Mohs and standard excision is simply how and when that edge is evaluated by the doctor.
And this brilliantly illustrates the concept. Think of the cancer like an irregular piece of property, and the surgical margin is its fence line. Mohs surgery creates a continuous, uninterrupted map of the entire fence line, checking the whole thing. Standard excision, on the other hand, removes a planned buffer around the property and checks scheduled cross-sections of that fence. Both approaches work. The core question is just whether the specific cancer and its location justify a continuous map, or if those representative cross-sections are enough.
So how does Mohs actually pull off this continuous map? It's basically a real-time feedback loop. First, the surgeon removes the visible tumor along with a very narrow layer of surrounding tissue. Next, that exact specimen is oriented, color-coded, mapped to the patient's wound, and processed so the entire edge can be evaluated under a microscope. And third, this is the real magic of the feedback loop. If cancer remains, the map tells the surgeon exactly where. They go back and remove another layer only from that specific mapped positive area. That's why Mohs is famous for being both margin-controlled and tissue-sparing. Now let's flip over and contrast that with how a standard excision works. First up, the surgeon removes the visible tumor plus a predetermined, guideline-appropriate rim of normal-appearing skin. That's the planned buffer we talked about. Second, the specimen is sent off to a laboratory. Finally, the lab evaluates it using vertical sections. In the medical world, this is affectionately known as bread loafing because, quite literally, the specimen is sliced up like a loaf of bread. It gives an excellent cross-sectional view at those specific locations. It's a well-planned, highly efficient, representative sample. Section 1. When mapped information changes the result. This data point is absolutely compelling. In a randomized trial for recurrent facial basal cell carcinoma with a 10-year follow-up, the recurrence rate after Mohs was just 3.9%. After standard excision, it was 13.5%. To put that into plain English, that's about 1 recurrence in 25 patients for Mohs, compared to about 1 in 7 for standard excision. That is a massive 71% relative reduction for this specific high-risk population. When a cancer has already come back once, a mapped microscopic search is incredibly valuable. Beyond recurrent cancers, mapping is absolutely vital for high-stakes anatomy. We're talking about the nose, eyelids, lips, ears, central face, hands, feet, and genital skin. Tissue preservation here isn't just about cosmetic vanity, it's about crucial physical function. On the eyelid, losing a few extra millimeters can literally affect your ability to close and protect your eye. On the lip, it affects speech and expression. Mohs is designed to spare healthy tissue while chasing the cancer, which is exactly what you want in these unforgiving locations.
Things get even more serious when we look at very high-risk cutaneous squamous cell carcinoma, or CSCSC, at 3 years. For local recurrence, it's 5.9% with Mohs versus 12.5% with standard excision. For cancer spreading to the lymph nodes, which is called nodal metastasis, it's 6.0% versus 11.6%. Even disease-specific death was halved, from 6.2% down to 3.3%. The takeaway here is profound. As the tumor's risk rises, having a complete mapped margin becomes increasingly important for local control and for survival. Section 2. When standard excision is a sound choice. Now, I want to be super clear here. Mohs is incredible, for sure, but standard excision is a highly efficient, familiar, and totally correct operation when the tumor meets certain criteria. We're talking about a primary tumor, meaning it hasn't been treated and come back. It's small with well-defined borders, classified as low risk under current medical guidelines, and located on the trunk or an extremity, like your back or your arm. In these cases, removing a planned clinical margin is safe, predictable, and honestly, the most logical choice. Using a complex mapped procedure here wouldn't add meaningful information, it would just waste your time.
So the crucial point is understanding the actual sequence of surgery. Treating skin cancer involves two distinct steps. Step 1 is cancer clearance, making absolutely sure the tumor is completely gone. Step 2 is reconstruction, deciding what flap or graft best repairs the hole that's left. The margin clearance strategy has to be completely settled before you start rearranging tissue with a major repair. If you move a bunch of skin around before you're certain the edges are clear and a piece of cancer was left behind, well, a second operation becomes incredibly complicated. Mohs settles step 1 on the very same day, so step 2 can happen immediately with total confidence.
Sometimes neither surgery is the right answer. Believe it or not every skin cancer requires a scalpel. Depending on the exact diagnosis, low risk or superficial tumors might be perfectly treated with EDNC, which is a scraping and heat method, or even prescription topical creams, or radiation. And for medically frail patients with a very low-risk basal cell carcinoma, careful observation might actually be the best path if the treatment would be harder on the patient than the disease itself. The treatment must always fit the exact tumor and the exact patient. All right, to empower you at your next dermatologist appointment, here are the exact questions you need to ask your doctor. Don't ask which surgery sounds fancier. Instead, ask, is my specific tumor low, high, or very high risk? Ask, how exactly will the margins be evaluated, mapped or cross sections? And most importantly, ask, would having a mapped margin during the surgery change the safety, the cure rate, or our reconstruction plan? If the answer is yes, you likely want Mohs. If the answer is no, a standard excision is likely perfect. We really hope this explainer has illuminated the path forward for you. Dr. Hocker created Skin Trust to provide free, evidence-based dermatology education and help patients and clinicians make clearer decisions together. Definitely share this guide with your dermatologist to start a great conversation. Remember, this is for general education and does not replace individualized medical advice from your care team. As you move forward, keep this final thought in mind. The answer to curing skin cancer isn't just in the removal. The answer is always in the margin. Thank you for joining us.